Welcome and thank you for coming to today's briefing. My name is Dan Perry. I'm the Executive Director of the not-for-profit Alliance for Aging Research. For those of you that may not be as familiar with the Alliance, we are a 21-year-old health advocacy organization seeking policies that will lead to a greater investment in scientific and medical research and better health care delivery for the growing numbers of older Americans. Today we are holding the second of a series of three-part briefings that we call Diseases in the Shadows. Members of Congress and their staffs get a great deal of information about high-profile issues or diseases related to older people, such as type 2 diabetes or cancer or heart disease or Alzheimer's disease. But we recognize that there are many other clinical conditions, very serious, very disabling, and very costly that fly beneath the radar or are in the shadows, as we call them. And for the past couple of years, we've been holding a series of briefings bringing expert witnesses and testimony closer to the policy process to give you a better appreciation of some of the diseases that don't often come to mind, but which are a serious part of our healthcare delivery process. They take a large bite out of Medicare and other forms of health payment, and they bring a great deal of misery, disability, and even death, premature death, to people as they grow older. In short, these are a series of discussions that we're focusing on dangerous and disabling, yet little understood and elusive conditions that we will see a great deal more of in our population as it grows older. Very pleased to have a partnership on these briefings with the Retirement Research Foundation. Retirement Research Foundation, based in Chicago, has committed itself to improving the quality of health care for older Americans, and this series of briefings is certainly part of that. We have focused in the past on conditions such as sarcopenia, which is otherwise known as muscle wasting, or on urinary incontinence, or age-related macular degeneration, or vertigo, conditions that really rob older people of their quality of life and add to the great cost burden. Today we're going to be looking at a particularly misunderstood, little understood issue that takes place when older patients are admitted to hospital or post-acute settings or other medical situations, and it's known as delirium. And we are pleased to have two nationally recognized experts on geriatric health care and specialists in understanding and measuring the impact of delirium on our patient population. And you know, there's always a personal story in almost all of these conditions, and let me share with you a grandfather of whom I was very fond, who was a farmer and a lifelong smoker and spent many hours riding on a tractor and inhaling the fumes from the exhaust of the tractor, had emphysema and was hospitalized when in his 77th year with an acute inability to breathe because of the emphysema. And as I heard from my grandmother later, she said, well, he just went kind of crazy. And the hospital staff strapped him to the bed, and during the night he died. So we didn't call it delirium in those days, didn't know the term, didn't know it was a condition that affects millions of American families. So this today is really the beginning of a process of shining the light into the shadows and bringing this particular issue today. And we're going to see a lot more of it unless we give our scientists and our health professionals the tools that they need to understand conditions like delirium, to help prevent it and to intervene effectively. Counting today, we are exactly 3 years, 3 months, and 11 days from that day when the first baby boomer will turn age 65 and enter the Medicare system, which will then grow. And in a very short time, 10,000 baby boomers a day will be turning age 65, and that will continue for the next 18 years. That's what some have called the pig in the python. That's the baby boom generation aging into Medicare and into a higher risk to diseases such as heart attack and stroke and hip fractures, which invariably will land them in a hospital for a period of time. And that's where the risks of delirium will be especially high. So this is an issue that may be a little bit beyond the horizon for some, but I particularly appreciate all of you for having the interest in how to deliver better health care to older Americans to be part of this briefing today. It gives me a great deal of pleasure to introduce our first speaker, Dr. Sharon Inouye. Dr. Inouye is a professor of medicine at Harvard Medical School and at the Beth Israel Deaconess Hospital. She is also the director of the Milton and Shirley Levy Family Chair and the Brain Aging Center at Harvard Medical School and Beth Israel Hospital. She was previously at Yale School of Medicine from 1985 to 2005, and her primary focus of her research has been on delirium and functional decline in hospitalized older patients, resulting in over 100 published articles. She's developed the most widely utilized standard tool for identifying delirium, and she's developed a multi-component intervention strategy to prevent delirium targeted at 6 key factors. So with that, I'd introduce and welcome to the podium Dr. Sharon Inouye of Harvard.
Thank you so much. Can you hear me back there? Great, thanks. So I'm going to focus my talk on post-operative delirium in older patients, delirium that follows major surgery. So let me start to tell you what delirium is. It's an acute confusional state, meaning that it comes on suddenly, and it's defined in medical terms as an acute change in mental state or thinking, and signs of delirium that we look for at the bedside are an inability to focus, inability to pay attention, rambling and incoherent speech, seeing or hearing things that aren't there, and either being very sleepy or alternatively being very hyper alert, like overly vigilant to what's going on in the environment. What I want to make a distinguish is that delirium is not acute Alzheimer's disease. I'm assuming that you've all heard of Alzheimer's disease, which is a more chronic form of mental deterioration. And I want to show you how they're different. This is delirium here, and Alzheimer's disease or dementia over here. Delirium has an acute onset, and Alzheimer's dementia has a gradual onset. They both have confusion, but with delirium, this confusion more affects awareness, the ability to focus attention, and with Alzheimer's disease, it more affects memory as a predominant feature. With delirium, the confusion tends to fluctuate. That means it tends to come and go. There's times of day when it's worse, there's times of day when it's better, and with dementia, it tends to be very slowly progressive over time. And the key thing that's very different, though, is with delirium, the symptoms tend to be reversible for the most part, meaning if you get this acute confusional state, such as in the hospital or after surgery, it usually does get better. With Alzheimer's disease or dementia, it tends to be irreversible. It's slowly progressive, and it will advance over time. But one thing I do want to point out is that delirium superimposed on dementia is common. And so someone can have a gradually progressing memory deficit and then be admitted to the hospital and develop an acute confusional state on top of it. So that does happen. So I want to show you some video clips of delirious patients, and the reason I want to show you this is mainly to show you how dramatic the confusion can be at the bedside, and so you can get a sense. These patients were cognitively intact at baseline for the most part. And with those clips, I also want to just point out that the first two patients were what we call hyperactive. They were agitated, they were very confused and active. The last patient is what we call hypoactive. She was very poorly responsive. She was in an intensive care unit, and actually that video clip was courtesy of Dr. Wes Ely, who will be our next speaker. So what do we know about delirium? Well, delirium is very common in older people, extremely common, and I'm going to give you some of the rates here from the literature from epidemiologic studies. For general hospital admissions of older people, it's present on admission in about 10 to 40% of patients. The incidence, which means the new onset of delirium developing while that patient's in the hospital, is from 15 to 60%. In the post-operative, post-surgical setting, from 15 to 53%. In the intensive care unit that Dr. Ely will talk about, from 70 to 87%. And in the nursing home setting, from 20 to 60%. And the mortality rates of this condition are very high. Hospital mortality ranges from 22 to 76%, and then on top of that, an additional one-year mortality from 35 to 40%. So I think you can see that it's a problem we really don't want to ignore. In addition, delirium leads to poor outcomes. There's an increased risk of death, complications occurring in the hospital with prolonged length of stay, increased discharge to nursing homes, slower recovery of function. Impaired thinking may persist for 6 months or longer in some patients, and also a tremendous degree of caregiver burden. So this is a burden on the families who must take care of these patients once they leave the hospital. So delirium does lead to markedly higher healthcare costs in the hospital and beyond the hospital. And just to give a sense of the hospital costs alone, about a third of our elderly Medicare age population is hospitalized each year, and they count for more than 40% of inpatient days of care. So if we assume a very conservative delirium rate of 20%, which you can see is very low from that previous slide, this means that 7% of all people, all older people in our country, will develop delirium each year. So delirium will complicate hospital stay for over 2.2 million persons per year, involving over 17.5 million inpatient days per year, at an estimated cost of over $8 billion per year to Medicare, just for the hospital costs. But the impact of delirium extends well beyond the hospital, and the costs are actually much higher once you leave the hospital because of institutionalization, rehabilitation services, formal home care that's required, and the amount of caregiver burden. And with the aging of our population, the baby boomers who are aging, as you've just heard about, this is going to continue to be a problem unless we can do something about it in the future. So I just wanted to say a word about the cost of delirium, because I think this really encapsulates one of the reasons why this problem is so important. We did a study where we looked at total health care costs for 1 year after a delirium episode, and overall costs were higher in delirious versus non-delirious patients, higher by about $17,000, and the adjusted costs per day were higher in delirious patients, and even when we adjusted for all other differences between those patients. So delirium is associated with markedly increased 1 year total health care costs and extrapolates to over $100 billion per year in the US. And this is an IMPRESS study by Dr. Doug Leslie that will come out later this year. So now I want to turn to post-operative delirium, which is making the increase in surgery in the older population is making headlines. Many more older patients are going for major surgeries now and having good outcomes, but one of the complications is delirium. This is from the US News and World Report, just showing that for many different major surgical types, the proportion of older patients is increasing. But delirium is the #1 complication post-operatively in patients, both younger patients and older patients. So 50 and over, it's still delirium. This is cardiac complications, non-cardiac complications, and this is delirium. And over age 70, you can see delirium is even much higher, almost 17% in that group. And a colleague of mine, Ed Marcantonio, has looked at how do we define who's at risk for developing this condition, delirium, before they go for surgery. And these are some of the risk factors that define high-risk patients. If they're age 70 or older, if they have cognitive impairment or dementia or Alzheimer's disease, they're at much greater risk. If they have any type of severe physical impairment, like a walking impairment, for instance, if they abuse alcohol, if they have markedly abnormal serum chemistries on admission, if they're going for aortic aneurysm surgery, that's a particularly high-risk surgical procedure, or non-cardiac thoracic surgery. So these are the two types of very, very high-risk surgical procedures. And then there are additional risk factors that occur after the person undergoes surgery that can also influence the risk of getting delirium. So if they lose a lot of blood and become anemic, that's something we want to try to avoid, particularly in older patients. If they receive medications that affect the mind, so these are things like sedatives, narcotics, there's a whole gamut of medications that can affect the mind. If they have uncontrolled pain, if they develop an infection, or if they're immobilized, meaning they're put to bed and they don't get up, they don't get exercise. All of these things increase the risk of delirium developing postoperatively. So what can be done about delirium? There have been a variety of intervention strategies, but this is one that we've developed that I wanted to mention to you, the Hospital Elder Life Program, which is our multi-component delirium prevention model. Oh, this is just to show you, you know, the hospital is supposed to be a place where you get some rest, but it really isn't very restful for most elderly patients. And I think if any of you have had experience with hospitalization, you know that the way hospital care goes is it's a 24-hour-a-day thing, and brain scans and all kinds of tests are done in the middle of the night. So it's really not a place where you get a lot of rest. But what we tried to do is we tried to identify and target these risk factors for developing delirium in the hospital, and you saw many of those on the earlier slide. And then we developed these sort of commonsensical, real-world, and not very high-tech interventions to try to put these into place to see if we could prevent delirium. And they were things like if someone was cognitively impaired, then we just provided them orientation. They had a dry erase board, and we wrote up the date, the day, who was taking care of them, and their schedule for the day. And that was updated 3 times a day. Gave them therapeutic activities. That was things like fun games, like word games, and relaxation exercises, and current events. We provided vision and hearing aids for people that were visually and hearing impaired. We got everybody up and walking so they weren't immobilized. We minimized the use of those medications that affect the brain. We provided, instead of a sleeping pill, you got a non-pharmacologic approach to sleep, which was a glass of warm milk or herbal tea, relaxation music, and a back rub. Very effective for getting people to get to sleep. Works on my son almost every night. And in fact, all the doctors came in requesting our sleep protocol too. They were on call. And dehydration, we had early recognition, and then we just pushed fluids orally if someone was dehydrated. And then we tried to make it so that people could sleep in the hospital at night, a very revolutionary concept. And so we had to do really a lot of coordination strategies, coordinate procedures, vital signs, IVs, breathing treatments, so patients could be woken up just once during the night rather than every 15 minutes for a different thing. And then we also tried to make the units quiet during the night. So this is our team making rounds on the patient. This is one of our volunteers walking a patient. This is another volunteer exercising a patient. And this is a volunteer doing a word game with the patient. And I think you can see it's a very high-touch, low-tech intervention, but it really allows us to introduce humanism back into medical care in a very real way. And this intervention has been shown to be very effective. We reduced incident delirium by over 30% on an absolute scale, and by a 40% relative risk. We prevented decline in cognitive and physical function. It was cost effective. We saved $831 per patient on average, and we also lowered long-term nursing home costs, saving almost $10,000 per long-term care patient. So what needs to be done? I was asked to say a few words about what more we need to do in terms of research, clinical, education, and policy about delirium. Really, I wanted to start by stressing that what is known about delirium to date really represents only the tip of the iceberg and what we need to know. And so some of the leading research questions are, does delirium itself lead to permanent cognitive impairment? It's really not known. We know it's tremendously common. We don't know if it indeed leads to permanent problems or not. And what are some of the fundamental mechanisms, the pathophysiology, or what are the really basic things that are causing delirium at a molecular level in the brain? Neurotransmitter abnormalities and so forth, we don't know that either. And there are no biomarkers, there's no real way with a laboratory test or an X-ray to diagnose delirium, and it would be very, very helpful to have something that provided us clues like that. And again, what are the effective treatments for delirium, pharmacologic and non-pharmacologic? And that's really not well known yet. Our program prevents delirium before it occurs. There as yet has not been a good trial to know what to do once delirium occurs. In the clinical setting, we really want to work to improve recognition of delirium by clinicians and caregivers. It's often missed. It's easy to miss at the bedside. Not when they're agitated, like those first patients in the video, but very easy to miss, like in that last patient, where she just seems to be sleepy and not really responsive. That's very easy to miss. We need to establish effective programs for delirium prevention, implement delirium guidelines and clinical pathways so clinicians know what to do when they see it, and try to enhance geriatric expertise at the bedside. We need to educate patients themselves, families, caregivers, and healthcare professionals about delirium. Again, we need to improve recognition, and I think we really need to enhance physician education about delirium at all levels of training. It wasn't something I was ever trained about or aware about in my training, but we've been really trying to change that more recently. And I think delirium has very important health policy implications, and I know all of you are involved in the policy domain, so I just want to take a minute to stress that delirium really serves as a marker for the quality of hospital care in the elderly, because it's often iatrogenic. It's caused by things like pain medications that can affect the brain or other medications. It's integrally linked to processes of care. It's common and it has bad outcomes. And so delirium can actually serve as a window for identifying quality improving changes. And so policymakers do play a really key role in providing incentives to improve hospital quality of care and for reducing delirium. So examples of things that would really help are things like designating delirium as a quality marker for hospital care, requiring hospitals to monitor it and to do something about it. That is really how to make this problem be acted on and to change. You know, when Medicare or the healthcare quality organizations require post-op wound infections to be monitored and reported, and you know, the tremendous amount of attention goes into that. So we would need to do something similar for delirium for it to be paid attention to. And something like mandating implementation of delirium prevention programs for Medicare reimbursement. I think you saw the costs of delirium. I think this would not be an unreasonable thing to try to do. So we have to make a change, and whether it's through a carrot or a stick, I don't know which is better, but you guys are the policy experts, so you know. So I hope you've enjoyed this delirium feast, and I just want to stress that, you know, our goal is to add life to years, not necessarily years to life, at least in geriatric medicine. So we want to keep our patients kicking up their legs. I couldn't do that at any age. Creating new memories and in roles that they enjoy to the end of their days. I just want to acknowledge the sources of that videotape. And that's it.
Thank you very, very much, Dr. Inouye. That's it's a great summary of the condition and some great ideas for how to intervene and even ideas for policymakers. Our second speaker is Dr. Wes Ely, who is a professor of medicine at Vanderbilt University. I've known Dr. Ely for many years. He was one of the very first to be selected in a very high elite program that selected physician scientists to focus on aging and on geriatrics, known as the Paul Beeson Physician Faculty Scholars Program in Aging. He's gone on to have an illustrious career in geriatric medicine and has also testified before Congress in the past. He's a subspecialist in pulmonary critical care medicine with a special focus on geriatrics. And in this capacity, he conducts patient-oriented health services research with a view toward improving the care and the outcomes of critically ill patients. He's also the founder at Vanderbilt of the intensive care unit Delirium and Cognitive Impairment Study Group. And he currently serves as the principal investigator on 2 clinical trials, both from the NIH and the Veterans Administration, on sedation and delirium in post-ICU cognitive impairment. And among others, and those are his main research focus right now. He's also written or has co-authored over 150 journal articles, many on this very subject. So we're very lucky to have 2 outstanding authorities on this little understood condition. Dr. Ely.
Thank you. Well, it's a great pleasure to be here today, and thank you for allowing me to come to you to present what I think is a complementary aspect or facet to what Dr. Inouye just presented. With her excellent background, let me now take you into the foray of basically what has become viewed as a new frontier in critical care, and that is essentially trying to save the brain damage, brain injury, acutely and long-term, that occurs for our critically ill patients cared for all over the world right now as we sit here in intensive care units. This problem of delirium and acute brain dysfunction that Dr. Inouye just discussed goes way beyond, for our society and for you in the audience, way beyond the issues of just post-operative care. We clearly have a problem in patients who do get surgery and then end up with a complication of delirium afterwards. But I'm going to paint a picture for you that describes how the demographics of this major public health problem extend so far into the reaches of our medical system and will no doubt touch you in your lives, either personally for yourself or through your loved ones. If in painting this picture, I can show you this patient here, whom I have permission to show, an elderly gentleman who was a retired postman, and was ticking along in life, doing very well with a great quality of life, no comorbidities or other medical ailments. And you can imagine your own father or grandfather with this same circumstance. The patriarch or the matriarch of your family very much enjoying the golden years of his or her life, and with virtually no warning, with just maybe a day or 2 of illness, lands all of a sudden in a hospital setting in an intensive care unit with a tube down their mouth, on a ventilator, because they've developed pneumonia, and the organisms that have caused the pneumonia, in this particular case, have gone into the bloodstream and created the disease of severe sepsis. Sepsis is a disease that you know because many famous people have died of this disease. For example, the Pope, JP2, you remember when he died several years ago, died of severe sepsis. The striking thing about this disease is that when the patient develops it, they are then ushered into the intensive care unit, if life support is chosen, put on the ventilator, and then given heavy-handedly large, if not truckloads, of drugs that keep them asleep for days on end while they so-called recover from this life-threatening multiple organ failure process. And many of them die. Those who survive go on to have a great deal of new acquired diseases, and those are the things that I'm here to tell you about today. There goes that buzzer on that funny clock again. So the demographics of this problem are what drive us. If you consider, for example, that critical care is now estimated to account for 1 to 2% of the entire gross domestic product. Many hospitals are indeed becoming like large ICUs all over the world, and you have to be very, very sick to even get into these hospitals. About 2,000 people today will develop severe sepsis and land in a hospital circumstance like the patient I just showed you. Indeed, right now, as you sit here, 55,000 people, or as you listen to this video, 55,000 people are on ventilators getting acute care in ICUs just in our country alone. And imagine how large that number is if you expand it around the globe. All of those people will have hospital costs of probably in the 6 digits, over $100,000 apiece. 2 out of every 3 of these people on those ventilators are 65 years and older. And as we discussed earlier with the pig and the python, this number is going to be dramatically larger as this large train comes down the track. Now, about 60 to 80% or more of these patients on the ventilator will develop this form of acute brain dysfunction that we call delirium. 60 to 80%. Think about the numbers. And of those who live, while many will die, because as Dr. Inouye pointed out, delirium itself is a predictor of higher likelihood of dying, longer stay, and greater cost. But of those who live, about 50% or more will go on to have a dementia-like illness. It's not necessarily Alzheimer's disease, but it looks and acts like a dementia in that the patients have problems with memory, executive function, going back to work, or dealing with whatever it was that brought them joy in the earlier days of their life. The demographics are what drive us. Look at this graph and look how the skyrocketing incidence of severe sepsis occurs right around the age of 65 to 70. There are very few diseases that have this sort of an exponential growth pattern at that age that are so life-threatening and so dangerous. Now, an anecdote can help. A patient I recently cared for, 64-year-old executive, with many people that are working for her. She's at the height of her career, extremely successful. As I said earlier, with little to no warning, she developed a pneumonia and severe sepsis. Before you know it, you're called to go see your mother or your friend, your loved one, and you find them lying in that bed on the ventilator. How could this be? They were so healthy a couple of days ago. And yet they are on death's edge with numerous organs that have failed. Dense ICU delirium that is difficult to break and difficult to treat and difficult to manage goes on in this patient for several days. In her lungs, heart, and kidneys and all the other organs came back well, no ongoing problems. In fact, because of her delirium and because of the inability to clear her thinking and her confusion, she ended up getting a CT scan and an MRI, which were normal, and she had no strokes or other predictable diagnosable problems with her brain. And yet, when she left, she had an extremely debilitating, if you will, executive dysfunction problem, which is now being increasingly described in literature, and was definitely unable to go back to work. She survived, and people patted her on the back and said, "Aren't you thankful that we saved your life?" But for what life? For what life? Because she was unable to go back to work, and she went on to have a very dramatic course of her life, which is depicted very starkly in this letter from her sister, which says, "Dear doctor, you remember my sister, who was the CEO, and I will highlight a few points. She has tried to go back to work and driving and functioning, although she cannot seem to fully bounce back. She seems to have lost her spark. She is very flat now and has memory problems. She looks like a very elderly woman now. The illness really changed her." This is what we're here today to talk about. Now, if you take a patient like this and test them as we do in our research, and as Dr. Inouye does in her research, and give them this test, which is one of many different psychological batteries which we provide, and ask her simply in front of you to copy this complex figure. Now, you might think that's somewhat complicated of enough figure, right? But you're looking at it when you're doing it. Do you think that you would actually look at this box and this one with a cross, and put the cross down at the bottom and not up here? Or that you would, instead of the pointy nose, draw a peg-nosed dog, and instead of a dangling diamond, put a block up here if you're looking at it? Okay? And what if then 30 minutes later I said, "Oh, listen, Sally, remember the drawing I had you do from a copy a minute ago? just draw me what you remember of it. Do you think you would confabulate and think that you had seen a house? It's so bad that it's almost comical. But this is what the nightmare that this person is living in. And yet walking around saying, Dr. Ely, thank you for letting me be here today. Other people don't know I'm having these problems. And to you, this would be invisible. It might pass right beside you as an unknown. So the brain dysfunction these patients experience is truly a new frontier. And there's a front end and a back end to the problem. And if you will allow me the analogy, the front end comes on when this healthy person or someone with mild comorbidities comes into the intensive care unit and develops the delirium and their other parts of their illness. And the back end is what they're left with after survival. When Sharon and I partnered years ago, right at the turn of the century, around the late 90s, year 2000, we began working together actually on this problem of delirium in the intensive care unit. And at that time, if you look about the literature throughout the 90s at the number of articles published on this topic, you can see there was nothing going on. It was dismal, and medicine had simply not gone there yet. Also at that time, in 1999, if you looked around the globe at this world map here, there were no places in the world that had routine monitoring of delirium for these critically ill patients. So it indeed was an invisible problem, a disease in the shadows. Jump now a decade later, and you can see this exponential growth of the number of manuscripts scientific journals are publishing on this topic. This is a new frontier, a new field that we are aggressively pursuing to try and get ahead of the train coming down the track of all of the elderly who are going to succumb and suffer from this disease. And furthermore, in the past decade, we now have validated instruments to monitor delirium that have been translated into 14 languages and are used in countries all over the world to help monitor for this problem. We haven't quite, I think, done enough, but we've made some progress, and it's going to be a long road. Now that's the front end issues, the monitoring for the delirium. But now let's get back to the back end issues. I can tell you that we are, as Dr. Inouye said, in the incipience of our understanding between the relationships between the delirium and the long-term cognitive impairment or the dementia. But we're making some progress. And our early data, which we're now working on, would indicate that, for example, every day spent in the ICU with delirium on the front end of this illness increases the chances by about 35% of a back-end ICU-acquired or accelerated dementia-like illness. So these things are part and parcel. The relationships and cause and effect we do not know and need to understand better. But I think that there are some things that we do as medical professionals that might be contributing to the problems, and those are some of the things that we need to focus on. Now there's a lot of information on different educational websites. This is one, the ICU Delirium.org website. And feel free to go to this website and communicate with me or our team if you have any questions on this topic. And anybody who's watching this video, all of our contact information is there. We view this as a partnership with the rest of society that we all need to work together towards accomplishing the greater good for the patients. On this website also there are information for patients and families and videos such as the ones that Dr. Inouye showed, which share both experiences during the intensive care unit and some very dramatic and poignant examples of people a year or two after critical illness describing very harrowing tales of them seeing people outside their window in the hospital, which were hallucinations, or imagining, quite frankly, that when people were managing their Foley catheters, that they were being raped in ICUs, and these sorts of very scary worlds that the patients are left to carry with them. So visit the website and learn more about it. And let me shift gears now as I come to the last two very brief sections of my presentation to discuss with you some related dementors that I think enter into the realm of the ICU. And just as J.K. Rowling in The Prisoner of Azkaban creates these very scary characters for us that suck the life out of the Harry Potter characters, there are no question some unrecognized management issues that act as dementors in our intensive care units. And these are things that I think are modifiable causes or things that contribute to the overall burden of the acute brain dysfunction that our patients suffer from. And we've been focusing on intervening in that regard to try and prevent or reduce the burden of the delirium and the long-term cognitive impairment. So I'm going to share with you just 2 of 4 ongoing clinical trials that we have just completed, one of which has to do with this truckload of sedatives and analgesics that I referred to earlier that patients get when they get put on a ventilator. You know, the patient I showed you, we kept him asleep for many days in the ICU with these sedatives and analgesics, much like your loved ones would be kept if they went to an intensive care unit now in this year and the ensuing years. Well, we had the hypothesis that a simple wake up and breathe strategy, which entailed stopping sedation and then stopping the ventilator once every day with close monitoring, could perhaps decrease the overall exposure that patients would have, unnecessary exposure perhaps, to the sedation and analgesia in the ICU. Always prioritizing pain control. And I never want to emphasize enough, never can emphasize enough, that we're not taking away pain medicine that people need for comfort. What we're talking about is when people get more than they need, and perhaps for a prolonged period of time where they don't still need the sedatives, for example. So this protocol was designed and conducted at Vanderbilt University and 4 or 5 others, including University of Chicago, St. Thomas Hospital in Nashville, the Hospital University of Pennsylvania, and Pennsylvania Presbyterian. At all of these sites, 335 patients were randomized to receive the wake up and breathe strategy or the standard of care. In this investigation, which is now under review for publication, patients given the wake up and breathe strategy protocol each day in the ICU, as compared to the standard of care, had a dramatic change in their outcomes. Think about this: 4 days less in the ICU, 4 days less in the hospital, and a 32% lower likelihood of dying at 1 year. This is the first investigation that has modified one of the main iatrogenic contributors to delirium in the intensive care unit that has ever shown a reduction in mortality, and yet quite a striking reduction in mortality. In fact, many of you have seen Kaplan-Meier curves in different investigations. Well, this is the Kaplan-Meier curve here, showing on the x-axis time out to 1 year, and on the y-axis the likelihood of being alive. And you can see that in the green bar, those who receive the wake up and breathe strategy have about a 10 to 15% increased chance, absolute increased chance, of being alive at 1 year, which was a highly significant difference. This translated into a 32% reduction overall in the hazard of dying if you do the math. Now, the second dementor that I'd mentioned is this issue that Sharon brought up earlier about sleep. Remember I said that the patients are kept asleep. Well, it turns out that while they are unconscious and you think that they are comfortable and asleep, they're really not asleep. And we monitor them now with these leads on their heads in the ICU and actually have sleep monitors at their bedside that I can actually even log on at home and monitor their sleep from my house or my office and tell that while this patient appears asleep and everybody thinks he's comfortable, he's actually never getting into slow wave or deep sleep, staying mainly at stage 1 sleep, never stage 3 or 4 or REM sleep. And this goes on for days. So imagine being in the ICU for 10 days, or imagine you right now in your life having 10 days with no sleep. Now imagine you're on the verge of dying when you really need that anabolic sleep and spending 10 days with no sleep at the point of being deathly ill. And then lastly, what if the very drugs you were on to help you were dramatically worsening the problem? Once we stopped the drugs in this patient, he then actually went to sleep. So there's a pathway to discovery here. The NIH has sponsored and the VA has sponsored us to study the relationships between the front-end delirium and the back-end dementia. And we have this ongoing brain ICU and mind ICU study. One last picture and then a closing slide. This is a picture of a patient who had severe sepsis, and at the time of the ICU discharge had a normal MRI scan. For those of you not used to seeing this, this white line here is the brain, is the calvarium, the skull. This white density here should extend all the way to the edge to the skull. But you see black in between because over time the patient has lost brain. Literally over time she has lost brain. And the questions are why. Her IQ went from 140 prior to her illness to 110 at 6 months and is now only back up to 118. This is a dramatic change for this previously very healthy and intelligent person. The U.S. News & World Report just did, in July, focus on this topic of their altered mental states. They wrote an article about delirium and cognitive impairment, and this quote, "The biggest problem is that doctors are focused only on the organs that got the patients into the hospital, ignoring the newly acquired brain problems in these elderly patients." So the last slide I have is that a quote by Ravelstein, the Nobel laureate, where he wrote about his being on the ventilator. "But my head, I assume it was my head, was full of visions, delusions, and hallucinations. These were not dreams or nightmares, because nightmares have an escape hatch." So it truly is a disease in the shadows, and I want to thank the Alliance, the National Institute on Aging, and the American Federation for Aging Research, and the VA for their efforts to battle for money, time, and research efforts to improve our understanding of this problem and to improve patient care for this disease in the shadows. Thank you.